So first line medical management, hormonal treatment, তাই তো? Hormonal treatment এর first line medical management what we have learned is, if a lady has come up to you, she does not need a child, her childbearing is completed and she is complaining of heavy menstrual bleeding because of fibroids or any other cause. First line drug what will you give? Hormonal drug what will you give? We will treat her with OCPs. So first line medical management for heavy menstrual bleeding is COCPs. Now, exactly. Now she says, no, I don't need hormonal treatments, I don't want to take hormone containing pills, but she wants to decrease her blood flow, like she has a complaint of heavy menstrual bleeding, she needs a symptomatic relief without any hormones. So what will you give her? How will you decrease her bleeding? You will give her progesterone the hormone, Tranexa or Tranexamic acid. So now you need to know about Tranexamic. What is the mechanism of action? What is the mechanism of action of Tranexamic acid? Anybody? This is a basic pharmacology question. Everybody should know. What is the mechanism of Tranexamic acid? Tranexamic acid. It decreases the bleeding how? Now, Tranexamic acid acts as inhibitor of plasminogen activator. So, eta plasminogen activator is inhibited. Plasminogen activator used to act what? It used to convert plasminogen into plasmin. What plasmin used to do? It used to, exactly, to fibrin into fibrin degradation products. They used to disintegrate fibrin. So fibrin used to make what? Basic work for clot plus clot stabilization. Now once this plasminogen activator has been deactivated, this entire pathway has been deactivated. So now fibrin is there, there is clot is there. So it helps in decreasing the, it helps in the clot formation as well as decreasing the blood flow. So this is the main mechanism of action of Tranexamic acid. So you can prescribe Tranexamic acid in a dose of 500 mg thrice a day up to maximum of 5 days. So this is basically a non-hormonal treatment for heavy menstrual bleeding. What are the side effects? The patient might complain of nausea, vomiting, allergy. Sometimes they specifically they complain of allergic reactions with Tranexa, which is very rare but is a very specific complaint. Bleeding home base. Exactly. Gum bleeding epistaxis, the drug of choice is Tranexamic acid. Yes, but it does not cause that much of thrombus formation that it will lead to DVT or pulmonary embolism. That it doesn't cause. Unless and until the patient is having some inherent coagulopathy, she is prone to thrombosis, she is a prolonged case of a malignancy, or she is some protein S or protein C deficiency, she has some inherent thrombophilias, then she is prone to develop such thrombosis de novo. But otherwise, giving a patient Tranexamic acid won't cause de novo thrombophlebitis or this DVT, nothing it will cause. So for in case of heavy menstrual bleeding, in case of fibroids, first line is hormonal, that is COCPs. If she does not want to take COCPs, then we can give non-hormonal treatment, that is Tranexamic acid. Other thing what we can give is, we have studied the non-contraceptive benefit of that thing. What was it? If the fibroid is not distorting the uterus, then you can give Mirena as well, because Mirena was locally releasing progesterone. As a result, it causes decrease in the size of the fibroid. See, first line is hormonal COCPs. Second is hormonal, again Mirena. Mirena, when you can give? When the size of the fibroid is less and it is not distorting. First, main selecting criteria for Mirena is it should not be distorting the endometrial cavity. If it is not distorting, you can very well give Mirena and counsel the patient that she will be amenorrheic, and one of the most important side effect is spotting PV. Now she says, you know, I don't want any hormonal drugs, then we can give Tranexamic acid. Now suppose all this mechanism have failed. Now comes to second line management. What is the second line management comes with? GnRH agonist. Name one GnRH agonist. Leuprolide. Leuprolide. And another Leuprolide, generally it is given as subcut or intradermal or IM. And another thing is Goserelin. Another is Nafarelin. Goserelin and Nafarelin are available as intranasal sprays as well. It is given as puffs, intranasal puffs. So how will this GnRH agonist act? They will simulate the action of what? GnRH releasing hormones. What happens is normally normal hypopituitary axis, hypophyseal pituitary axis, how it functions? It releases pulsatile release of GnRH. But once you give an external continuous stimulation, like we are doing with GnRH agonist, it causes what? Causes down regulation of the HPO axis, as a result of which causes decrease in all the hormones. As a result, the size of the fibroid decreases. It has been seen that if you give most of the time how we give Leuprolide we give in a way that suppose the fibroid is too big and she wants to preserve her fertility. She doesn't want hysterectomy. She wants to preserve her fertility. But the size of the fibroid is so big because once you try to do myomectomy for that fibroid, or there are multiple fibroids, so you won't be able to do it and there will be huge blood loss. So what we do is we plan in such a way that we give GnRH agonist like Leuprolide for 3 months. Within 3 months, it has been seen that is almost 40% reduction in the size of the fibroid. As well as what happens? The patient becomes amenorrheic. So the bleeding decreases, her anemia gets corrected, and then you can very well do the operation, right? So the main advantages of GnRH agonist is for correction of anemia, symptomatic relief from the pressure symptoms by reducing the size of the fibroid. So what is the dose of Leuprolide? It can be given as IM monthly 3.75 or (11.75) 3 monthly. Now the question arises, if we give GnRH agonist for more than 6 months, then what happens? If we give GnRH agonist like Leuprolide for more than 6 months, it causes what? It causes a hypoestrogenic state. As a result of which what happens? There is bone mineral loss. There will be decrease in the bone mineral density. The patient will be much more prone to fractures, vaginal dryness. So if you are planning that there are certain indications or certain treatment guidelines which says you have to give, there is no other option, you have to give GnRH agonist for more than 6 months. Then what we do, we start having add-back therapy. What is add-back therapy? We give estrogen and progesterone supplementation simultaneously so that she does not land up in hypoestrogenic state. Now one of the major side effect of this GnRH agonist is the flare effect. Because once you are giving this agonist, there is chances of hot flushes, this hyper hormones are released in such a way that there is flare effect. So to counter this flare effect, we have another category of drug, that is GnRH antagonist. So name 2 examples of GnRH antagonist as well. These GnRH antagonists are now being widely used. Now previously Leuprolide was very popular for the treatment of fibroid, endometriosis and everything, but now after this advent of these GnRH antagonists, these drugs are being rampantly used. So what is the name of the drugs? Elagolix and Relugolix. And one of the major advantage of this GnRH antagonist is what? These Elagolix and Relugolix are available in oral forms. It is not an injectable form. Elagolix, Elagolix and Relugolix, Relugolix. These are the oral preparation. These are not the injectable preparation. The patient can take it by herself. She does not have to go anywhere else. And this GnRH antagonist, especially Elagolix, is working wonders in case of endometriosis treatment. Because endometriosis is a what? Endometriosis is a hyperestrogenic state, and by giving GnRH antagonists like Elagolix, what you are going is a hypoestrogenic state. So the patients are responding very well. Similarly, it is in case of fibroids also, it is decreasing both the estrogen as well as the progesterone. As a result, what is happening is the shrinkage in the size of the fibroid, as well as the anemia correction, as well as what major advantage it is having with over the agonist is that it does not have the flare effect as well. So side effects are also omitted. Now other drugs what we use for this medical management of fibroid is Ulipristal acetate. Where we have studied Ulipristal otherwise? Contraception, for emergency contraception. Ulipristal acetate was used as an emergency contraceptive. It was given up to maximum of 120 days. So here in case of uterine fibroids, Ulipristal acetate can also be used. What is its mechanism of action? Selective progesterone receptor modulators, not agonist or antagonist. It can act as both agonist as well as antagonist. So that is why it is known as SPRMs, that is modulators. So how it decreases the size of the fibroid? It causes down regulation of the progesterone receptors over the fibroids. As a result, it decreases the VGEF, that is vascular endothelial growth factor, as well as its receptor, both. It decreases both. As a result of which what happens? The blood supply to the fibroid decreases, as well as the size of the fibroid is also decreasing. But the major disadvantage of using this Ulipristal acetate is what? It is hepatotoxic. So that is why before starting Ulipristal acetate, what we need to do is we have to rule any kind of LFT, that is liver function test abnormality. And once the Ulipristal acetate is started, it should not be given for more than at a stage for more than 3 months. It is given 3 mg per oral for maximum of 3 months in one go. And once the patient is having Ulipristal acetate, she needs to get her LFT done every month. So once before starting Ulipristal, then monthly while she was on Ulipristal, and then again liver function test has to be tested 2 to 4 weeks after stoppage of the therapy. Another drug which decreases the size of the fibroid, that is what? That is Mifepristone, or it is used in treatment of fibroid under the name of RU486. So where we have studied Mifepristone previously? Contraception as well as abortions, right? So how does it act? Again the same way. How does it act? Exactly. Emergency contraception as well. How does it act as an emergency contraception? How does it act as for this thing, abortion? Same mechanism, but how?
Abortion and prostaglandin কাজ করছে আর এমনি প্রোজেস্টেরন কাজ করছে
হ্যাঁ কি করবে? How? It is what? It is anti-progesterone. Progesterone antagonist. Once the progesterone decreases, the endometrium becomes more sensitive to endogenous prostaglandins. As well as what happens, endogenous prostaglandins causes what? Increases myometrial contractility. And once there is no progesterone, what is happening? The implanted blastocyst is not surviving, so it causes abortion. The same way it is a progesterone antagonist. So as a result of what happens? It is increasing myometrial contractions, there is no blood supply, the size of the fibroid decreases. It is given 5 to 10 mg per oral. It is also found that with 3 months of treatment, there is decrease in the size of the fibroids for more than 30%. So these were the drugs what we use for medical management of fibroids. So if anybody asks you what is the first line medical management of fibroid is? Combined pills. Then Mirena. If the endometrial cavity is not distorted, then non-hormonal contraceptive is non-hormonal method of decreasing heavy menstrual bleeding is tranexamic acid. Then second line drugs are agonists and antagonists. And then other off-label drugs are this Ulipristal acetate and Mifepristone. Okay. Then what we have to study is this 2 drugs for ovulation induction. So what is the mechanism of action of Clomiphene Citrate? Again, same thing. Whatever drug you study, you have to know the mechanism of action as well as its side effects. Clomiphene Citrate, Citrate. What was the mechanism of action? SERM, selective estrogen receptor modulator. So where it acts as both agonist as well as an antagonist, right? So where does it act as an agonist and where does it act as antagonist? Clomiphene citrate acts as estrogen receptor antagonist at the level of pituitary, at the breast and ovaries, and it acts as an agonist where? It acts as an agonist in endometrium and the bone. So how do you think, if it is acting as an antagonist in the pituitary, how do you think that it is causing ovulation or it is increasing the causing ovulation induction? At the level of the pituitary, if it is acting as an estrogen antagonist, then it what happens? It is giving the body as a false perception of low estrogen levels in the body. As a result of what? That this pathway is getting activated, as a result of which increase FSH and LH secretion is occurring. Most importantly, FSH increases, as a result of which number of follicle recruitment increases. As a result, ovulation. It acts as an ovulation induction drug. But at the level of endometrium and bone, it acts as an estrogen receptor agonist. As a result, which causes what? It causes an increase in the endometrial thickness. As well as at the bone, it increases the bone mineral density. So it is a causing beneficial effects on both sides. So now what is the major disadvantage of Clomiphene citrate? It is increases the chances of ovulation hyperstimulation syndrome. Dose is 50 to 150 mg. How will you start Clomiphene citrate? From day 2 to day 3 of the menstruation up to 5 days. Then ask the patient to come for folliculometry where we monitor the size of the dominant follicle and keep on increasing. For first cycle you give it for, suppose first cycle you give 50 mg OD for day 2 to up to 5 days. Then you from day 10, day 11 onwards, every alternate day you start monitoring the size of the follicle. and see what is happening. If she is not responding, then next cycle you increase the dose to 100 mg. Then again you increase the dose to 150 mg, but maximum up to 150 mg only you can give, and maximum, most of the guidelines says that you can give ovulation induction maximum of 6 cycles. After that, if it is not working or she is not getting adequate size of a dominant follicle, we say she is Clomiphene Citrate. What is the difference between Clomiphene Citrate resistance and Clomiphene Citrate failure? Read this and come and tell me in the next class. What is the difference between Clomiphene Citrate failure and Clomiphene Citrate resistance? Now another ovulation induction drug is letrozole. And what is its mechanism of action? Letrozole is an aromatase inhibitor. Since it is an aromatase inhibitor, where do you think that this drug is being used as an ovulation induction? Yes. Hyperestrogenic states, there will be, letrozole will be used as an ovulation induction drug. Then where is this hyperestrogenic state occurring in your body? The patients who are having PCOD, right? So they are having hyperestrogenic state. You need to decrease that hyperestrogenic state. So you need an aromatase inhibitor for that, because aromatase causes conversion into estrogen. So this is the drug of choice for ovulation induction in case of patients having PCOD. What is the dose? It is given 2.5 to 5 ODHs from day 3 of menses to day 7, that is 5 days. Then same way we monitor the size of the follicle. It is said that compared to Clomiphene citrate, letrozole is having successful pregnancy rate is also higher with letrozole, live birth rates is also higher with letrozole, and chances of ovulation ovarian hyperstimulation syndrome is also less with letrozole. So letrozole is kind of beneficial compared to Clomiphene citrate. So these are the basic ovulation induction drugs. For UG, you need to know this much. Another drug is this one, Rotavirine. Everyone will be very much familiar with this drug, right? Rotavirine. Yes. What is this? Antispasmodic. How it causes antispasmodic effect? Then it increases the CAMP and CGMP. As a result, it causes the smooth muscle relaxation and causes the antispasmodic. So where are its uses? To give me 2 obstetric uses and give me 2 gynecological uses. It's a 1 gynecological use. Yes. Another. Ectopic pregnancy we never use. Exactly. See, you can easily differentiate between a false labor pain and a true labor pain, because false labor pain is basically a spasm of the smooth muscle of the uterus without any progression of the labor or any other cervical dilatation. So if it is a false labor pain, with rotin it will decrease. But if it is true labor pain, then the pain won't subside. And it is sometimes given in the active phase of labor to decrease the pain sensation and make the patient comfortable. So nothing much about Rotavirine. Now we need to know about this thing, Bitnisol, Betamethasone and Dexamethasone. So what these drugs are used where? If these are steroids, it is mainly used in obstetric purposes. Where do we use? For fetal lung maturation. Which one will you prefer to give, dexamethasone or betamethasone? Why dexa? हाँ मैंने why dexa? You could have given betamethasone as well. Both are have the same efficacy. हाँ हाँ साइड ना দুজনে সাইড ইফেক্ট সেম না সেটাও সেম ই হয়
এটা অলরেডি অ্যাক্টিভ ফর্মে আছে
See, what happens is, whatever compound we are having as dexamethasone, it is dexamethasone sodium phosphate. Okay. This dexamethasone sodium phosphate having equal efficacy and everything same as to betamethasone acetate plus phosphate. If we are getting this compound betamethasone acetate plus phosphate, if this two salt combination of betamethasone is available, then this compound and this compound is having the same efficacy, same T-half, same beneficial effects, same side effects, nothing is wrong. But what is happening in India is, we do not have this combination of this salt. What is available is only acetate or only phosphate. Now what happens, this only acetate or only phosphate is very unstable compound. It has storage issues, it has to be stored in a specific temperature and specific everything, as well as its T-half is low. So what happens, the efficacy of this drug reduces. So if the combination of this salt is available, then these two are equal efficacious. But if it is not, then we prefer as to use dexamethasone sodium phosphate only. And what happens is, since India is a resource limited state, so dexamethasone is a life saving drug as well. So it is easily available in any rural parts of India as well. So that is why Government of India recommends to give dexamethasone. So what is the dose of dexamethasone? This is a vial of dexamethasone. See, this is the vial of dexamethasone. It contains what? This is a 2 ml vial containing 4 mg. So each vial contains 6 mg. So we total dose of dexamethasone is 24 mg. So 2 ml e 4 mg. Total আছে 6 mg. না 2 ml. Total 24 to be given 12 hours apart. Try 4 doses. 4 doses. See, one vial is of 2 ml. 2 ml into 4 mg. It has total of 6 mg. So 6 mg, 4 doses, 12 hours apart. Total 24 mg. Today you give 6 mg, 12 hours apart again give 6 mg, 12 mg. Next day again give 6 mg, 12 hours apart again give 6 mg. 12 mg, 12 mg, 24 mg. Done. 1 ml 4 mg. Okay, no, that is not the thing. Not 3 ml, 3 ml, 3 ml, 3 ml. So. Ratio টা হ্যাঁ 2 ml 4 mg 3 ml আছে তো total dose is 24 mg and for betamethasone it is 12 mg 24 hours apart if you are getting this salt. Now when will you give? You will give it between 24 to 33 plus 6 weeks. If delivery is imminent within 7 days or within 48 hours, whatever. Suppose a patient is at 28 weeks and she is complaining of lower abdominal pain, and now you examine her and see, okay fine, the cervical os is also open and it is getting dilated. She is at 28 weeks. Now what will you tell her? Yeah, that's why we need the lung maturity. So we need to give her dexamethasone injection. As well as what we did, it is also given by the Anganwadi workers as they give the preliminary dose of dexamethasone and then they refer the patient to a higher center. But it has been always said that give a dose of dexamethasone, because what it reduces the 33% reduction in fetal mortality, then 37% reduction in necrotizing enterocolitis, and most commonly it also decreases the risk of intraventricular hemorrhage, and 67% decrease in the risk of neonatal respiratory distress syndrome. So, the examiner often asks you the question, what is the advantage of giving betnesol or this dexamethasone as a steroid coverage? It not only decreases respiratory distress syndrome, it decreases the incidence of all these, of intraventricular hemorrhage, of necrotizing enterocolitis, as well as decreases the overall fetal mortality as well. Where will you not give? Suppose she is in preterm labor, she is at 28 weeks, but you are not giving dexamethasone or betamethasone. Suppose she is having a history of prolonged rupture of membrane, she is complaining of fever as well as foul smelling discharge, and you suspect that she is a case of chorioamnitis. So, there is already a ascending infection over there. So, now if you give her betnesol or any other steroid coverage, exactly, she will go into immune suppression and it will lead to flaring up of the reaction. Exactly. So, in case of chorioamnitis, that ascending infection is there, so you won't give dexamethasone or betamethasone over there. And dexamethasone is an emergency drug, it is always readily available. The dosage is standardized by the government of India as well as it does not require any storage preparation, it can be stored anywhere. So, that is why we prefer to use dexamethasone sodium phosphate. So, these were the remaining drugs. The drugs has